invite the next speaker, head of the glaucoma department and the glaucoma surgery research group at the University of Geneva Clinic, president of the International Society of Glaucoma Surgery, and our friend Tarek Shaarawy, and he will discuss and compare trabeculectomy, non-penetrating options, and micro-invasive operations for glaucoma. What should we choose? Welcome, Tarek.
Good afternoon. It's a real pleasure and an honor to be part of this excellent symposium. I have collaborated a lot with my Russian colleagues over the last couple of decades, and I have I have the most respect for the Russian School of Ophthalmology, and I remember with a lot of fondness all the big names from the Russian glaucoma community that added a lot to the quality of care that we are providing to our patients for the last century probably. So thank you once again, and I've been asked to speak about the dilemma of choices when it comes to glaucoma surgery. It is indeed a dilemma. When I was a resident, all what we could do to our patients were probably trabs, and tubes were introduced a few years before I started my residency. So I dabbled with Barvelt and Ahmed early on in my career. But it was very clear from the beginning that glaucoma surgery is both a science and an art, a science that relies on logic, analysis, and communication between you and your patients, and an art form that has a lot to do with your experience, your intuition, your emotions, and obviously your ability to be creative. So I have a career in glaucoma surgery that started with trabs and deep sclerectomies and tubes. And after years, many devices, white hair and less hair, I have gone all the way to the MIGs, including the Zens and the PRESERFLO. And glaucoma surgery is indeed something that is very efficient because we can drop the pressure to decent levels, so a good intraocular pressure reduction. It does not rely on compliance of the patient. It provides an intraocular pressure that is over 24 hours, and it is quite economical in many places around the world where the economies are quite challenged, especially with this whole story of the pandemic. But it comes with a long list of complications that you are all well aware of. I would like to stop a little bit and discuss complications that are important to glaucoma surgeries, because complications are important drivers for us as we decide and make choices. Two of those complications that are very important would be visual loss and loss of comfort, as in with bleb dysesthesia. It is really important for us to understand and evaluate everything that has to do with efficacy and complications, and not to be guided by false knowledge. Edward Said, a famous Palestinian Orientalist, once said that the greatest enemy of knowledge is not ignorance, but is the illusion of knowledge. Now, the options that we have traditionally have been trabs, tubes, deep sclerectomies, and cyclodestruction traditionally, but nowadays you can see all what you can see in front of you now. All those are devices that are either FDA approved or CE marked, and they rely on 4 different types of mechanisms or strategies to reduce the pressure: either filtration in the subconjunctival space, or enhancing Schlemm's canal filtration through the conventional pathway, or going into the suprachoroidal space, and finally destroying the ciliary body and closing the tap, thus reducing the production of aqueous and reducing the intraocular pressure. So which one to choose? Well, there's no one hat fits all. There's always the question of patient by patient. It's a patient-specific choice. It is based on your assessment of the risk and benefit for this specific patient. And this would entail an intellectual process that sometimes happens in a fraction of a second and sometimes can take days. It depends on the difficulty and what is at stake. And then obviously you have to explain well your assessment to your patient and the choices that is in front of the patient. Probably we usually recommend a specific choice after having exposed the patient to different options, and the patient's opinion does matter. So there are lots of specific subtle determining factors for the patient that might not be your own determining factors, things that has to do with safety, with comfort, with ability to preserve vision, with ability to get back to work, with ability to cover or not the eye, with his history, that is physical history and psychological history, as well as his family history. When you're treating somebody that had a sibling or a parent that lost vision because of glaucoma, things can be only very different from what you're doing. There's always the evidence-based approach. But to be very honest with you, we have not compared everything with everything to be able to come out with some clear recommendations. One step in the right direction was the publication of the guidelines on design and reporting of glaucoma surgical trials. It's an endeavor that I have undergone with Mark Sherwood and Franz Gren, as you can see, and it aims at asking researchers and surgeons to publish and to design their work in the same method so that we can at least compare well between studies. Make no mistake, comfort and safety for the patient is on the highest level of the patient's priority, and this is data that has been published. And if you look at something like the TVT study, the trab versus tube study, well, there is a loss of 2 or more Snellen lines after 1 year in 1/3 of cases of trab or tubes. Are we telling our patients that there is a chance that the vision will drop? Well, we owe it to them to cite things like that. And then in many cases that are bleb dependent, you have created a bleb that has destroyed the perfect topographic surface of the eye. And in many cases, in about 10 to 15%, there's bleb dysesthesia, meaning bleb discomfort, which means that the patient suffers from having a bleb in his eye. And blebs like the ones that you see here are not fun, and they are associated with astigmatism. They're associated with Dellens. And you also have blebs like those when we use mitomycin, and you can see the amount of oozing of aqueous coming out of the bleb wall, which basically means that this is a malfunctioning bleb, which is usually associated with hypotenuse and the potential for blebitis and endophthalmitis. This is something that we have to work out. So when we focus on our choices, we have to ask ourselves, are we properly estimating the incident of visual loss and loss of comfort? And have we lost track of patient-oriented outcomes? Are we telling the patient, go for this procedure because of reasons that are not 100% related to the patient, but partially dependent on what we want? This is, I think, is very important for us to identify with ourselves. Now, there is the potential for loss of qualitative and quantitative vision with glaucoma surgery. There is a potential for loss of eye comfort and loss of quality of life. So as you can see here, our evaluation has to look at risk benefit for every specific patient, for every specific eye of every specific patient, to be able to provide good recommendations. And then we look at all that is now available to us. So I was from the school that started non-penetrating, that pushed for non-penetrating glaucoma surgery. That's 20 years ago. I still do a lot of non-penetrating glaucoma surgeries, but the options in front of me are now vast. And I owe it to our patients just as much as you owe it to your patients to make the right choices. Deep hysterectomies still are some of my best choices. I remove the site of aqueous blockage, the resistance, the maximal resistance of outflow, as you can see in the inner wall of Schlemm's canal and juxtacanalicular trabeculum. So it is perfectly, it's a perfect procedure in terms that it really targets the site of the disease in primary and secondary open angle glaucoma, but it is not something that will work for every patient. You can see here aqueous is coming, we're not losing the anterior chamber, but I can do that for an angle closure glaucoma, I can do that for a neovascular glaucoma, and at the end of the day, I rely at least partially on a filtration bleb with all the potential complications that comes with a filtration bleb. You can always argue with a deep sclerectomy, we can do agoniopuncture. As you can see here, we perforate the trabeculoidesmens membrane and reduce the intraocular pressure, but that even that comes with a certain price, as there is a percentage or a potential possibility of an iris prolapse into the intrascleral space, causing peaking of the pupil, and unfortunately will result into issues that would probably drive you to take back the patient to the operation room. Now, MIGs came in and it stirred again the murky waters of glaucoma surgery. And the whole idea of going into MIGs was to improve visual outcomes and improve the comfort level and reduce the risk. So basically, this is what we wanted to do from MIGs. Did it actually comply? Did it provide that? To some extent, yes. I have to be honest with you that the jury is still out. We don't have conclusive evidence about MIGs because we don't have long-term data, but we know, for example, that we have something called the hybrid blebs. Hybrid blebs are blebs that are related to the fact that a lot of those procedures like the pressure flow or the Zen implant, as you can see, are filtering 6, 7, 8 millimeters away from the limbus. So they are not limbal blebs, and blebs that are far away from the limbus are more comfortable to the patient and have a higher chance of providing a better outcome because they scar much better than those near to the limbus. And you can see one of those blebs after a pressure flow. It's diffuse, it's far away from the limbus. It looks like an ideal bleb. Not every single bleb after a pressure flow is like that though. And complications can happen after a pressure flow or after a Zen implant. You can see here an erosion, and we're basically picking out the implant. And another complication from the same case, it left a suprachoroidal cleft and they had to take the patient into the operating rooms. So loss of vision after MIGs can happen, complication after MIGs can happen. So now, after having spoken about all that, what is right and wrong? What are the choices? What are the decisions that we're making? And I can only give you my choices based on decades of working in glaucoma surgery. Well, non-penetrating glaucoma surgery has been and still is the most popular surgery that I'm doing, especially for primary and secondary open angle glaucoma cases that have not been opened before, inversion eyes. For angle closure glaucomas, I will always try phakic ones. I will always try to do a phaco first, removing the lens before doing anything to reduce intraocular pressure surgically. And if the pressure is still high, I would do a trabeculectomy in pseudophakic angle closure glaucomas. Tubes are reserved in my armamentarium for refractory glaucoma cases, including uveitic glaucoma cases and neovascular glaucoma cases. And MIGs are my best choice for combined phaco glaucoma surgery procedures. Pressure flow at this point of time is a procedure that I have a lot of interest in, and I'm using it in mild and moderate open angle glaucoma cases, especially in obviously inversion eyes. So I'm not incredibly adventurous at this point of time. I can put patients into, after informed consents, into specific studies. But I'm telling you here my choices that are related to my day-to-day practice. So again, glaucoma surgery, a science and an art. I wish you all the best. I wish you the greatest success in your careers and in managing your patients. And I warn against peer pressure. Peer pressure is one of the well-known cognitive biases that surgeons can suffer from. Don't be under pressure because a person next door is doing this and you are not doing that. Stick to the right choices, make a good assessment of what you can do and what you can't do, and consider the drivers that are now current drivers related to glaucoma surgery. We need to do glaucoma surgery as preserving vision and preserving comfort level. We need to do procedures that don't need years of learning curve. And in many cases, we need to do combined procedures. And with all that in mind, everything that we have to do has to be cost effective. So with that, I thank you very much. It has been an honor to be invited to this beautiful symposium. I am honored, and I am looking forward to listening to all the other lectures from my peers and my friends.